Welcome to EASL Studio, your weekly hepatology broadcast news. In today's episode, we will see EASL guidelines on vascular liver disease to be published this year, and particularly what's new in these guidelines. I am Pierre-Emmanuel Rautou, professor of hepatology in Beaujon Hospital in Paris, in France, and today I will be accompanied by Professor Valérie Vilgrain, who is radiologist in Hôpital Beaujon, in Paris, in France, by Professor Juan-Carlos Garcia-Pagan, hepatologist in Barcelona, in Spain, and Professor Sarwa Darwish Murad, who is a hepatologist in Rotterdam, in the Netherlands. To start with these guidelines, I would like to ask you, Juan-Carlos, a question about a topic you worked a lot on, which is patients with cirrhosis who develop portal vein thrombosis. And one of the questions we have is, does the cause of cirrhosis, muscle D, hepatitis C, etc., and its treatment influence the development of portal vein thrombosis?
Thank you, Pierre-Emmanuel. Thank you, everybody, for being here today. Well, actually, this is a very important question, and I think that we have not a definitive answer, although there is some evidence suggesting the muscle D is probably one of the most frequent or an etiological agent that causes more frequently PVT. In patients with cirrhosis secondary to muscle, PVT seems to be a little bit more frequent than in the others. But I think that the main message that we need to remind is all cirrhotic patients can develop PVT, although maybe, as I said before, muscle D may be a little bit more frequent. And what is important is to recognize that despite the treatment, at least in hepatitis C, despite that we treat and we cure the virus, still the risk of developing PVT remains. That means that we need to follow our screening of every 6 months to identify the possibility that our patient has developed PVT.
Okay, so risk factors for cirrhosis, maybe muscle D associated with an increased risk, and if we treat the cause of cirrhosis, the risk of portal vein thrombosis persists. Okay, thank you very much, Juan-Carlos. One more question to you. In a clinical setting, we do regularly ultrasonography to search for hepatocellular carcinoma, and it happens that we find portal vein thrombosis in patients, particularly in the one that are the most severe. But the question could be then, why not treating all our patients with cirrhosis with anticoagulants to prevent development of portal vein thrombosis? Is that realistic? What do you think about that? I think you had some data also not particularly related to portal vein thrombosis. Can you tell us a little bit more on your view in this aspect?
Well, I think that probably because still we don't know what is the impact on the natural history of cirrhosis, of the development of PVT, especially depending on the extent of this PVT. I think that the quick answer to that is for the moment not, although there are some evidence that suggests that maybe anticoagulation by itself, because of different pathophysiological mechanisms, may improve the natural history of cirrhosis itself, even without the need to prevent the development of PVT. There are 2 studies, one with enoxaparin at prophylactic dose, another one with rivaroxaban at prophylactic dose, that suggested, unfortunately the sample size was not very large, but suggested that maybe in comparison to no treatment or placebo, the treatment with this type of anticoagulants may improve the outcome of our patient with cirrhosis. However,
this is the results of the CIRROXABAN study that has been presented 2 years ago from the Spanish group, isn't it?
Yes, this is the results of the rivaroxaban study and also of the study by the group of Italy from Dr. Abila with enoxaparin that suggests that maybe the treatment with those prophylactic doses of anticoagulants may improve the outcome, may reduce the development of portal hypertension complications during follow-up. But still, we need more evidence before recommending this treatment for these patients.
Okay, so the target currently is not portal vein thrombosis prevention. But beside this target, maybe in the future, anticoagulant could prove useful to decrease the risk of decompensation. Is that this, Juan-Carlos?
Yes, you are completely right.
Okay. Sarwa, a common question we receive in the clinical setting, where we do again follow patient with cirrhosis, screen for HCC, portal vein thrombosis. Should we perform in those patients with cirrhosis screening for risk factor for thrombosis?
Yeah, thank you very much, Pierre-Emmanuel. I also want to thank the organizers for inviting me in this excellent panel. I think that's indeed a question that we are very frequently asked in the clinic, especially when the thrombosis is quite extensive. Should we be worried about an underlying thrombophilia? And the answer really is no. I think several studies have really investigated the incidence and the prevalence of all sorts of thrombophilic risk factors in patients with cirrhosis and PVT. And there was no increased presence of those in this group. So the idea of the PVT in cirrhosis is really more related to the Virchow's triad, being that low portal inflow. We all know that portal velocity, when it drops below the 15 centimeters per second, it has an increased risk of PVT. And then also an imbalance in coagulation, and perhaps also the shear stress of the portal vein wall in the setting of cirrhosis and portal hypertension. So that may also explain why the PVT increases in incidence when the cirrhosis severity increases. So no, the answer between screening for thrombophilia, I think, is not needed. Unless, of course, there's a different reason to screen the patient for thrombophilia. For example, if there's a history of multiple extrahepatic thrombosis unrelated to the cirrhosis, or maybe even before the development of cirrhosis.
Okay, so no systematic screening for a risk factor for thrombosis in patients with cirrhosis, unless there is something specific that orientates you towards searching a cause. This is also what you do, Juan-Carlos, in Barcelona. You don't search for risk factor for thrombosis?
Yeah, we don't look for that because if there is no other clinical sign that suggests that maybe there is a thrombophilic disorder patient that may have also thrombotics in other settings, or a high number of platelets or something like that, but not routinely. Okay,
so the risk factors are really related to portal hypertension. So again, coming back to our clinical setting, we find in a patient with cirrhosis at the time of screening portal vein thrombosis, the question thematically we receive it: should we give anticoagulants to all these patients with cirrhosis and portal vein thrombosis? So what did we say, Juan-Carlos, in our guidelines to be published on vascular liver disease? Can you summarize a little bit for our audience?
Yes. Well, the recommendation is mainly based in the extension and in the situation of the patient in relation to be a candidate for liver transplant or not. Okay. If the patient is a candidate for liver transplant, and because we know that portal vein thrombosis, it progresses and makes difficult physiological anastomosis of the portal vein anastomosis during liver transplant, this is associated with a poor outcome of this liver transplant, then our threshold to treat this patient is much lower, and we are actually recommending to treat any type of PVT in these patients just to prevent progression. And this is a specific group of patients that are in the waiting list, or that may be in the waiting list soon or in a short period of time. The situation is
on the waiting list, or maybe, because this is two different
maybe in the waiting list in the future. No, if they are for sure, if they are going to be in the future, or they are potential liver transplant candidates, the same argument applies. Okay,
so they are in the waiting list. Shape A patient where you find portal vein thrombosis, 50-year-old, no contraindication to transplant. Do you treat this patient with anticoagulants?
Yes, the answer is yes.
Okay, so potential candidates.
Yes, potential liver transplant candidates. The situation is a little bit different if the patient is not a liver transplant candidate, because as I mentioned before, the impact that PVT promotes in the natural history of cirrhosis is not so clear, although there are more and more evidence suggesting that anticoagulants are good for these patients. And then if the portal vein thrombosis extends and occupies more than 50% of the lumen, we know that that produces a much higher increase in portal hypertension. And then we consider that if the extent of the thrombus occupies more than 50%, probably this patient should always also be treated. The situation is a little bit different, and then there is a case-by-case discussion when the occlusion of the lumen is less than 50%. In this situation, of course, surveillance is recommended to discard that there is progression, and anticoagulation should be considered in case by case, but it is not completely mandatory to apply it in that situation.
Okay, so that's clear. Patients who are potential liver transplant candidate, meaning no contraindication to liver transplantation, then you go for anticoagulation. If they are not, if they have contraindication to transplant, over 50% you strongly consider, below 50% of occlusion, then it's more case by case. Okay, that's very clear. The question with HCC, Juan-Carlos, this is a difficult situation also. You find the patient with cirrhosis, portal vein thrombosis, not tumoral invasion. This is very clear, portal vein thrombosis. How do you manage those patients? Do you treat those patients with anticoagulants?
Well, I would consider the previous considerations, but in that case, probably my threshold to treat with anticoagulation is much lower, and probably I would suggest, if there are no contraindications, even those with less than 50%, because in this patient, it is known, it has been demonstrated very recently that PVT deteriorates or worsens the outcome of these patients, and probably I will treat all of them with anticoagulation. If there is no anticoagulation, and what is here important, you already mentioned, is to be sure that this is not a tumoral thrombosis, but these are really, it's not a tumor, but it's a thrombus.
Absolutely. Okay, yeah, because if the portal vein thrombosis is occluded, then some treatment of hepatocellular carcinoma are not possible. So I guess this is the reason why you consider treating those patients. So we have a question systematically about what anticoagulation, because you heard that Juan-Carlos wants to prescribe a lot of anticoagulants to those patients with cirrhosis, but it's not so simple. And the question we have is the DOACs, the direct oral anticoagulant. So should all our patients be treated with these DOACs, rivaroxaban, apixaban, edoxaban, or is that contraindicated? So can you clarify a little bit and guide us into the best management for our patients?
Sure. Yeah, so historically speaking, we're all much more familiar with the treatments with vitamin K antagonist or low molecular weight heparin in this setting. However, we also know that these are also not ideal treatments, especially if you're treating long term and in the setting of the vitamin K antagonist, that it affects the MELD. So the DOACs are quite attractive in this, but we also know that all the registration trials for the DOACs basically systematically excluded patients with liver disease, including patients with cirrhosis. So any use of DOACs in this setting is actually off-label, and it still is off-label. But that said, there is increasing observational data that in Child-Pugh A cirrhosis and also in Child-Pugh B cirrhosis without renal insufficiency or other potential contraindication for DOACs appear to be safe. Safe enough to be used, and obviously they offer these advantages compared to the vitamin K, because you don't have to rely on the INR and the monitoring thereof. In Child-Pugh C, I think the answer is still no, do not use the DOACs because we really are not safe. And I think there's a few more things that I always tell my fellows: if you do use DOACs, then you should be careful, because INR can actually be slightly elevated with this as well. So obviously the impact on the MELD score is not as high as with vitamin K, but don't be surprised when you see this. And the other thing is that in the setting of the liver transplantation, when their patient is high on the waiting list, it's probably wiser to convert back to low molecular weight or vitamin K antagonist because of the transplants and the need for reversal of the DOACs. So we know that these reversal agents are available, but they're still quite expensive and not that much used.
So, meaning that in patients without renal insufficiency and not on the transplant list, you go for JPUG-A DOACs green light, JPUG-C DOACs red light, and JPUG-B what, orange, green? What do you say?
I think if only JPUG-B without any other comorbidities, I think it's probably okay, but I will be careful monitoring the patient.
Okay. We discussed, Juan-Carlos, also the tips for portal vein thrombosis in the guidelines, EASL guidelines. Isn't it a little bit surprising to discuss tips to treat portal vein thrombosis? Could you tell us a little bit more about this strategy? When, how? Is that pretty useful? So tell us a little bit.
Well, I think that there are two different clinical conditions. With that, one is a patient that comes with a severe complication of portal hypertension that arrives to the hospital with a variceal bleeding episode or with maybe severe ascites, and then you identify PVT there. Then probably TIPS should be considered as a potential option in these patients, taking into account potential contraindications. And this can be always considered because in some cases, there are two studies at least that I know that they suggested, because the sample size was low, that patients coming to the hospital with a variceal bleeding with PVT, treating them with TIPS was much better controlling the bleeding episode, but not survival when they compare with the standard of care, that is vasoactive agents or plus endoscopic treatment. Then I think that you must always consider this possibility. The other situation is when we have decided to treat our patient, the patient in the transplant waiting list, and that we identify PVT, maybe 50% of the portal vein trunk, and then after 1 month, we do an ultrasound and we saw that despite anticoagulation, there is a progression of PVT. Then again, you must consider the possibility to do a TIPS to try to maintain the patency of this portal vein for a potential future liver transplant. And these, for me, are the two potential indications of TIPS in patients with PVT.
Okay, so either a portal hypertension complication, you treat this patient with portal vein thrombosis with TIPS, or if there is no response or progression with anticoagulants, then you go for TIPS. And it works?
Yeah, of course, it works. It works quite well. But again, I would not say that is mandatory in these two situations. You need to consider that if there is progression that do not respond, sometimes we realize that the patient is not taking adequately the anticoagulation, but you need to consider, okay, this patient is taking, we are in a risk area because it's now in the mesenteric vein that it was not before. I go for TIPS. If there are, the patient is a good candidate for TIPS. And again, if the patient arrives to the hospital with a very severe refractory ascites, probably my threshold to decide, okay, I will go for a TIPS will be much, much lower. I always consider that. But I think that is not mandatory because also they can work with the technique. But imagine a patient with refractory ascites that you need to do large volume paracentesis with anticoagulation. That makes the things much more difficult. And then probably TIPS could be a very good option.
So to be considered. Valérie, we place a TIPS in a patient with portal vein thrombosis. So the clot goes to the lung, therefore it creates pulmonary embolism. So isn't that a little bit crazy to do this? What are the data? Could you tell us a little bit?
Fortunately, this does not happen in all cases. TIPS placement in those patients with portal vein thrombosis is a complex procedure and is even more complex than regular indications for TIPS. So indeed, complications are seen more often and are about 10% But fortunately, the risk of pulmonary embolism is much lower and is something about, I would say, 1% according to the meta-analysis that has collected something like 400 patients. So it's a major complication. This complication can be fatal, but fortunately, it is quite uncommon. And indeed, the most common complication that we may face is bleeding.
So this is generally a safe procedure. Okay, Sarwa, in a clinical perspective, we have this patient with portal vein thrombosis. We treat with anticoagulants. We place the tips according to what Juan-Carlos told us. But there, after the tips placement, what do you do with the anticoagulants? Do you maintain? Do you stop? What is the recommendation?
Yeah, that's always a difficult clinical scenario, but I think it kind of pertains to what we discussed before, like what's the pathophysiology of the PVT in the cirrhotic setting. And if we concluded that it was due to low flow and portal hypertension, then the TIPS basically improves both the portal inflow and also the portal hypertension. So that may already protect from recurrence. So it was tested in a small randomized trial whether then anticoagulation would improve the recanalization and recurrence further, and it was not found to have a difference. So the current evidence is not supportive enough to say routine anticoagulation should be given after successful TIPS placements. But of course, in practice, it kind of depends a little bit on some individual factors, how extensive the portal vein thrombosis was. So sometimes it can be a case-to-case decision, but routinely speaking, the evidence doesn't exist to continue.
Okay. So, portal vein thrombosis in patients without cirrhosis. Therefore, the question I have for you is, Valérie, is how do you know that a patient with portal vein thrombosis does not have cirrhosis, in fact? Do you do systematically liver biopsy?
No, indeed, the question is very clinically important as it may impact indications and follow-up. And well, there are two ways to diagnose cirrhosis, the invasive one with the liver biopsy, but also the non-invasive one, imaging-based. We can do that with several approaches. First, the classical one with the changes in the liver morphology, in changes with the liver surface nodularity, signs of portal hypertension, and morphological changes that are associated to cirrhosis. We know that these findings are not necessarily sensitive, but quite specific. But indeed, the best modality today, or the best approach, is to look at liver stiffness, which is certainly the best way to diagnose non-invasively cirrhosis. So it might be a combination, or we can go straight to the liver stiffness and so liver elastography technique.
Okay, so because we have imaging which bases the diagnosis of portal vein thrombosis, we take advantage of that to look at the liver, and we perform liver stiffness measurement. Juan-Carlos, any threshold to consider there is cirrhosis, no cirrhosis? Which one would you tell to our audience?
Yeah,
one word. You don't have the 2 minutes. One word. What threshold?
Yeah, the threshold probably it's 12, or 12 for cirrhosis, 20 if you want to be sure that the patient has a high probability of having portal hypertension. And I understand that the patient that we are evaluating has portal hypertension.
Okay. So let's move to patients with portal cavernoma, chronic portal vein thrombosis. This is a difficult question about the management of anticoagulants in those patients. Shall we continue? Shall we stop? Sarwa, what do you think is the best approach in those patients with chronic portal vein thrombosis?
Yeah, that's always a challenging question, because now that the fresh thrombus is gone, then should you just still anticoagulate these patients? And the answer really is depending on what caused the portal vein thrombosis. So first of all, even when you identify the patient with a portocarcinoma for the first time, so you don't know how long or ago the recent thrombus developed, you should always do a complete workup of underlying thrombophilia. And we also know that then if you find a patient with major, we call them then permanent risk factors for thrombosis, we know that the risk of recurrence of the thrombosis is present and is high, whether inside the liver or outside the liver. And those are then the patients that I would treat with anticoagulation. And what do we mean then with the major and the permanent risk factors? So those are the patients that have an underlying myeloproliferative disorder, a personal or a first degree family history of thrombosis, those with antiphospholipid antibody syndrome, those with homozygous factor V Leiden or protein 2 mutation, PNH, malignancy, and Behçet disease. So those are really the patients that we should look for to treat. And then all the other cases is always a difficult question, should you still then treat or not?
Okay. So risk factor for thrombosis, strong risk factor for thrombosis, this is easy, you treat with anticoagulants, and the other, so what do you do?
Yeah, so we know that the recurrence rates are not zero in this group, although we think that the recurrence rates are quite low. So the decision usually is a multidisciplinary one. We take that with the hematologist, we do the full workup, and we see maybe some minor risk factors, but also we weigh in the patient's in an weight decision, so the shared decision making.
Multidisciplinary decision.
Yeah, multidisciplinary and also shared decision making with the patient, kind of weighing in the benefits versus the risk of bleeding in that particular patient.
Okay, thank you very much, Sarwa. So there is still a time of multidisciplinary discussions and also room for more studies. We discussed in these guidelines a very difficult topic, in my view, which is the Splanchnic artery aneurysm management. Valérie, you work a lot on these questions as part of these guidelines, and I've got some questions for you. First, simple one, what is the difference between the Splanchnic artery aneurysm, but also as compared to the pseudo-aneurysms? Is that the same? Is that different? Could you tell us a little bit more?
Thank you. Yes, it's an important topic and it's not very well known. And it is important to distinguish these two entities, what we call the true aneurysm from the pseudoaneurysm. They differ in many ways. The first one is the mechanism and the physiopathology. In a true aneurysm, the arterial dilation involves the three layers, the intima, the media, and the adventice, while in pseudoaneurysm, only the outer part of the vascular wall, the adventice, is dilated. This is the first difference.
I suppose they are more fragile, maybe.
Exactly. And consequently, the risk of rupture is very different. And this is why the patient management will be very different if we consider patients with pseudoaneurysm or patients with a true aneurysm. Another difference is the cause. We know that most of the true aneurysm are related to arteriosclerosis, or might be congenital, or might be associated to diffuse vascular disorders, where we usually have local cause, local etiology for the pseudoaneurysm, like a trauma, like iatrogenic conditions, infection, inflammation. So these are currently the most important differences, and also the location. If we look at the prevalence, just as an example, most of the true aneurysm in the splanchnic regions will be in the splenic ones, while the distribution might be very different for the pseudoaneurysm. So major differences.
Okay, so major differences in terms of pathophysiology, risk factors. So tell us a little bit more how to manage, because when we see this image, it is always the question, shall we treat or not those aneurysms or pseudoaneurysms? So what, practically speaking, should we do?
Okay. Before managing the patient, we should diagnose. Just a very brief word.
Yes.
The CT is the imaging modality to diagnose and stage splanchnic arteries. It's far better than ultrasound, far better than MR. And with CT, we not only diagnose, but we assess the location, the extent, we look for associated disorders. Now the patient management is driven really by the risk of rupture. And as we have said, it's much higher in pseudoaneurysm than in true aneurysm. So generally speaking, for the pseudoaneurysm, the treatment will be indicated whatever the size, while other factors will be taken into account for the true aneurysm. First, the size, and we know that there is a threshold not completely defined between 2 centimeters and 2.5 centimeters, but below this threshold, the risk of rupture is much higher. Second, there are some factors, despite the size, that can predispose to rupture, like a patient in the pre-liver transplant setting, or women, pregnant women. That's why probably we should have be cautious in a childbearing woman, and also in fast-growing aneurysm, meaning that even if there is no decision for intervention because the aneurysm is a small sized, we will have to monitor it and record the evolution over time. That might change patient management.
That's very clear. Thank you so much, Valérie. We are already reaching this the end of this episode, this EASL Studio episode. I would like to thank you a lot, Sarwa, Valérie, Juan-Carlos, for sharing with us the work you did as part of these guidelines together with the whole panel. Then I would like to tell you that EASL Studio Season 8 is over now, but you can watch all the episodes on demand on EASL Campus, and we invite you to join us for Season 9 of EASL Studio in September. And in between, remember, become a member and enjoy EASL family. Thank you very much.
Thank you.
Thank you very much.
Bye-bye.
Bye-bye.